of botulinum toxin in refractory incontinence in 2020. When we look at two women in 2020, young and not so young, let's just look at the scenario that they go through in a non-life-threatening issue. My boyfriend and I don't go out very often because of my problem. If we do go out, for example, to a departmental store, the first thing I look at is the toilet. If I can't find one, I leave the store. That's how serious this problem is. And Dr. Pandey has put me on combination medicines, which is not working. She's young, 27 years. When you look at 2020, refractory overactive bladder in not so young population, 67 years old, Mrs. Rao. She said, having this problem is so bothersome. For instance, I totally avoid taking the bus, no buses plying anywhere in the country, anywhere. But because I can't ask the driver to stop when I suddenly have the urge to go to the toilet, can I? Also, I always wear dark clothing and carry extra pads wherever I go, just in case I leak something. And Dr. Pandey has put me on combination therapy, which is not working so well. So there are patients in this large A to Z of incontinence who are overactive bladders and urogenic detritus or overactivities, where the control between bladder and brain, the control levels have gone to such levels where we understand that we have to take this to the next possible level. And that's where we look at the evidence and experience and the expectation of these individuals who are not in a life-threatening condition. In other words, is botulinum toxin the answer? Is that what you and I are asking? And is there an ideal patient for botulinum toxin? Perhaps yes. With the kind of paradigm shift that has happened in this disease in the last 20 years, with the kind of understanding that we have had, the kind of trials and the kind of papers which emanate from centers which do great work on this, the kind of anecdotal reports that we have from colleagues and the collection data that we have, I think it's time for us to look forward to this patient's agony, where urgency, the bottom line of the entire component, which she cannot postpone or he cannot postpone urination, and goes on to such levels where they're agonized every day in their awake hours. So if there is an answer available according to the algorithms that we prepared and that we look forward, we go to the next level to help us out to understand that this rhythm which has got disturbed to refractory states, the patient deserves therapy, and that is what is a wake-up call. So in those progressive understandings that we had in the era from overactive bladder to urogenic detritus or overactivities and the pathophysiology and the results, we're looking at safe upper tract, we're looking at stabilizing the situation. And while paradigm shifts happen, we move from unknowns to knowns. We are much better off in 2020 that we already arrived in India with the Indian guidelines. We know that we are stronger on the guidelines than anybody else. Just quoting that very page which Dr. Sinha, the chair from these guidelines, did quote about, is about the invasive therapy when it comes to urinary urge incontinence, from which we were quite reluctant to in the past era. It looks forward to the ONA botulinum toxin type A, with all the dose-finding studies which happen across the world in the trials. We stand tall when we inject 100 units of botulinum toxin into this refractory overactive bladder states. And we have looked at the results, and there are studies emanating that we stand extremely tall, and we'll be able to take it forward to the next level. Can I just recap this for my colleagues in practice and my colleagues who are actually taking this subject up in various levels, that we're not dealing with the disease at this point in time. That's what AAU, SUFU guidelines do speak. They talk about it being a symptom complex, which generally is not a life-threatening condition. And therefore, across the table, it's a doctor-patient relationship understanding how much is the agony to treat and how much is the patient already suffering from. We know these patients live on diapers, less water intake, searching for toilets and not taking the best buses in these cities. We need to balance that benefits and risks, the burdens of the disease, the available treatments, and what would suit the patient best. And that's what we have been doing. We've been looking at this symptom complex which threatens the patient regularly with those episodes which actually threaten their life with urgency and incontinence. In other words, we have ingrained in our treatment the first line therapies. Just a quick recap on that we have this as a part of therapy, and we keep revising that with the patient on every visit that the patient follows up. Are you following all this? Are you attempting to do all this? While that is happening, the second line therapies is what a urologist is capable of and has been doing at different levels around. We look at the oral antimuscarinics and the beta-3 agonist, which has so deeply ingrained in our practice in the incontinence scenario of this kind. We look forward to adverse events and understanding that. We look at caution in the right kind of patients we see, which means that don't use antimuscarinics in patients who have got non-angular glaucoma, and my ophthalmology colleagues will tell that it's not a very uncommon situation. We also look at these patients who have got gastroparesis and who have got past history of retentions, who are those patients who have got already an anticholinergic burden in the body with various medicines which have got anticholinergic burden. And then we look at old and frail patients who could be hypertensives, who could have this cognitive dysfunction, which could only be worsened with the antimuscarinics. and maybe hypertension could go haywire with the new therapy that we have on. But the combination therapy, which we have understood so well, we look forward to the last point 16, that if there are individuals who are refractory to the behavioral and the pharmacological therapy, even the combination that we do in today with very sacrosanct Indian guidelines, we look forward to appropriately working up these patients and taking them forward. In other words, it's a patient who a lot governs this treatment and requests or demands or begs and says that, can I go to the next level? Can I get from a moderate therapy to a better therapy? Can I be dry again? So in those patients, the third line therapy has been, by guidelines, the botulinum toxin type A. For an overactive bladder, the dose finding study looked at 100 units, and the 100 units have been used now rampantly across the cities and countries. We looked at the neurogenic detrusor overactivity in the era when we used to inject everybody 300 units and land up in retention and maybe UTIs. We came down to a level of 200 units, which is a standard dose for neurogenic detrusor overactivity of the kind of patients which a gynecologist, a urogynecologist, and a urologist sees, the kind of patients who are cerebrovascular accidents, the Parkinson's disease, the multiple sclerosis, and possibly the stroke patients. They could be qualifying into the therapy of refractoriness from the day one, because they are already refractory overactivity. They are because of the neurogenic overactivity gone wrong. So these patients need an extreme degree of counseling, trying to understand that we're improving their quality of life with the ifs and buts which can happen in a disease process and the therapies that we're giving around. In other words, we're going to look at the post-ward residue should not go so high. The post-therapy urinary tract infection should not be a life-threatening situation. And those things have to be ingrained in a patient counseling therapy sessions that we do as a pre-operative or a pre-injection workup. We look at these patients understanding that we are not going to go ahead and have a situation where the patient did not understand the therapy. So just quickly recapping that refractory overactive bladder has not been a loose term. It has been a term which we have taken to very high levels in those era where there were anticholinergics and you are failing 2 anticholinergics over a 12-week period. And they're looking at, now this patient probably climbs up in the algorithm to go through a minimally invasive therapy, lest he may require an surgical therapy. In the present era, when we have got a combination therapy already so well being used in our country, failing full dose of combination therapy, which could be the beta-3 agonist as 50 milligrams and 5 milligrams of sulfenacin, the most standard of the medication being used on the anticholinergic team. We look forward to this combination therapy failing and would label them loosely as refractory overactive bladder. Now, this very subject of refractory overactive bladder did undergo its own sea revolution from country to country, from era to era, and we saw these stalwarts talking about what does refractoriness mean. That means a patient can no longer manage himself with phase 1 and phase 2, the first and the second line managements, and could be a candidate for that. So chancellors, Niti, Chappell, Backer, and co all had their own definitions, and I'm not going to that. We're looking at, we have climbed on the shoulders of these giants who have actually worked extremely hard, brought the subject to such levels that our patients could benefit. And therefore, when we look at these busy slides which we have been given across, and then we hover and move around, and we look at those patients who actually are thoroughly counseled on moderate and severe symptoms, and sadly cannot handle themselves, where the guidelines in latest 2019 Indian guidelines talk about refractory urgency, which is just not possible to manage in UACAs. We'll look forward to the therapy that we were given to by the US FDA approval in 2011. So we as urologists were the latest kids on the block in 2011 when we got this FDA approval for Refractory Incontinence, for neurogenic detrusor overactivity, and the OAB form. We became stronger by understanding that this drug could treat all the afternoons, and good afternoon everybody again. In these afternoons could be much better off, minus the loss of bladder control which these individuals suffer from. So the 2 patients who were overactive bladder, who were 27 years young and not so young, 67 years old, while on anticholinergic therapy and while Dr. Pandey put them on a combination therapy, hoping that they could probably get better, escape diapers and escape the departmental stores with trouble. When we looked at their urodynamics patterns, we look at them sadly that they don't look like the normal ones. They have their filling phase grossly active. The bladder contracts, they leak out, and they actually are patients who deserve it. So it's patient who tells you what the therapy is required. It's all about a documentation in today's era and looking forward to following the guidelines. And that is what we have been doing. Since I'm sure everybody has this book because that we are revising this chapter. If not, I would like to pass the PDF to the true group, and probably everybody should have the PDF format of it, where we and the team across worked on and looked at botulinum toxin in that era and inhibiting the neurotransmitter release, which in a skeletal muscle would work approximately for 3 months. And therefore, we all remember that our colleagues in physical medicine and rehabilitation, our colleagues in urology, look into various patients and disease states where they inject on the muscle levels for various kinds of spasms which happen in the limbs post-recovery neurological states, and where they get these injections to a little higher dose than what we give. We need to be aware that while this temporary chemodenervation works for approximately 3 months in striated muscles, I use that in refractory vaginismus, where it is only effective for 3 months. That has been the trial in the United States by the US FDA. But in striated muscles and in vaginal muscles working for only 3 months, whereas in the bladder, it's now working from 6 to 9 to 12 months. Therefore, the activity on different muscles at the different cholinergic nerve terminals where the resprouting happens back is different for different muscles. A Pandora's box which is being just sorted out. So looking at a little bit of activity which happens for a colleague, a urogynecologist, a gynecologist, and a urologist, he does a good checklist. He looks at that this patient deserves by all workup, all requirements, a minimally invasive therapy for the urge incontinence or overactive bladder or the NDO. Look at these cultures on these patients. Unfortunately, if they are on a clean intermittent self-catheterization, they always have bacteria as a part of commensals, which is transgressing the urinary passage. We look at the anticoagulants, look at the entire patient profile into what kind of anesthesia to get in, and look at the concomitant medications they have been on, which sadly have been failing around. When we look at the reconstitution, it's all about understanding that reconstitution is about a freeze-dried situation of a powder, which is labeled as either a powder visible on the Make in India campaign, which the INTA-BOT or the INTAS group has just come up, and the old age strong medicine, which we always have got as Botox or the Botulinum Toxin available. It should not be shaken and cause bubbles, which could then be difficult. So on the table, the Botulinum Toxin reconstitution has actually been epitomized, and we don't move forward on that. But the preoperative on table is extremely important, which means we're looking at the antibiotic cover for this procedure and never an aminoglycoside, because it again, being a cure, has again a musculoskeletal relaxation issue and therefore recovery from patients under general anesthesia. A preliminary cystoscopy is always warranted before we get into the vial and get reconstituted. So reconstitution always happens after a urologist, a urogynecologist, and a gynecologist have actually done a preliminary cystoscopy, gone through the urethra, not picked up a stricture or not picked up a growth in the bladder or a large stone in the bladder, which may have missed out for some reason in the workup. Then open up the right vial of a unit, which could be 100 units. 100 units are available by the INTA-BOT in India as a Make in India campaign, and 200 units is available for the NDO directly as a single vial with the Botox. We know the technique of admixture of these vials very well. We use preservative-free normal salines, and we should get the vacuum feel, which is very important as the plunger goes in gradually and preventing any air bubbles. If the vacuum feel is not there, probably your vial has been contaminated, not to use as the answer. So botulinum toxin from the before therapy on the table, it all talks about looking at the landmarks. If you looked at the urethra, some gentlemen who may have a very large prostate and a median lobe may actually jeopardize your injections into 20 and 30 sites as you choose. So map the bladder with the landmarks, which is the bladder neck, the trigone, the ureteric orifices, and that saliently moving air bubble, which also happens to be landmark for us to know how do we climb on this. Look at a partially full bladder is the bladder that we'll be using. Not too full a bladder, then most of our injections would go out, and lesser full a bladder will be all about indenting the mucosa and not being able to give the right injections, even if you have the new needle. So a partially full bladder will be more defined as we learn our tricks on the train in dummy saline injections. Cystoscopy being such a normal procedure. And then we're looking at the feeling of comfort we have about this injection doing good to this patient. So a partially full bladder will be required. The needle bevel gives a click. The click which is heard by your fingers, not by your ears, is that you know that this is clicked across the detrusor. You're doing a suburothelial injection, which is a combination of submucosal and intradetrusor. It usually happens even the best of hands across the world that we raise a bleb. We raise a wasting across the needle on both sides, and that's the wasting which will cross to the next injection. We look forward to not raising blisters. Blisters could be too superficial. Blister would be one where the mucosa is actually completely blanched and looks white. That is something which would not be beneficial. Trigone was not injected in ERA, but the area of bladder pain syndrome and a lot of papers emanating, which I went through yesterday, 2019-20, bladder pain syndrome, I see is coming back again. And people are researching in Asia Pac on that region. We look forward to that could be a new modus operandi, but that we are discussing right now only incontinence. I'm not sure this video will play, so I'm just moving forward. Looking at points to ponder when we complete this in a more crisp way is that when do we propose botulinum toxin type A or botulinum toxin for the patients whom we need to give. So for the refractoriness that we know on these patients who complain, and a lot is there on the warding diary. We understand that the warding diary is something which helps us to take it to the next level. To this patient with refractory overactive bladder wet, need urodynamic evaluation before intradetrusor injection. Yes, a documentation is a great idea because you are getting into a therapy. You may pick up new things and many more things which will be invisible to what the patient has complained. What is admissible level of baseline this patient sure getting into a clean intermittent self-catheterization? It almost warns me that the neurogenic detrusor or overactivity, who has been attempting to spontaneously void by all medications being given to him to void and get a control, is actually going to trouble his upper tracts or his upper tracts only in jeopardy. He is a patient who should be dry completely for his social atmosphere, get into a already high residual volume, getting more high after 200 units of botulinum toxin for an endio component, save his upper tracts for future, and get into a clean intermittent self-catheterization every 4 to 6 hours. So we will put forward thumpingly that if you deserve something, you deserve a clean intermittent self-catheterization, that you are an active man in the city and country. You got to be more active, not being wet, not being on diapers, but obviously don't jeopardize upper tracts, which is looking like already